Can you check the, yeah. Good evening, everybody. Thank you, sir. I would be speaking on strabismus evaluation. I know neurophthal is going to follow, and this is quite a dry topic, another dry topic. But I would be taking care of, so strabismus is basically broadly divided into two categories. One is the motor aspect of strabismus, and second is the sensory aspect of strabismus. The motor aspect of strabismus is the aspect which normally, we get to see in day-to-day practice. And sensory aspect of strabismus is what makes it more interesting. Sensory aspect of strabismus tells us whether it is actually the both eyes which are working together or not. So what exactly is strabismus? Strabismus is basically the misalignment of two visual axes, which means that when both the eyes are not straight, there is some strabismus. It could be manifest, it could be latent. It is manifest when you can see that there is a strabismus when the patient walks into the clinic and you can see that there is an eye which is out, in, up or down. And it could be latent when you see that both eyes are straight, and when you do an alternate cover test, you can make the strabismus manifest. So what are the goals of examination? The goals of examination are first to establish whether there is a presence of strabismus and what is the type of strabismus. Whether there is a presence of strabismus is a must, because if there is no strabismus, we would just go to sensory examination, check for his binocular vision, and then he is good to go. And second thing is to establish the type of strabismus, which means whether it is ezo, exo, hyper, hypo, what is the type of strabismus. Whether there is any presence of amblyopia, it is very important to know beforehand. Whether there is any presence of amblyopia or not, because that gives you to formulate the plan of treatment. And third thing is what is the amount of deviation for management, because when you plan for your surgery, you need to know how much exactly the eye is out or in or up. And then after all this, you should never forget to test the binocular sensory status, which is very important, because it gives you a lot of clues whether you should operate early or you can wait or you can give some orthoptic exercises. So we will see it one by one, but before, whenever you are going to write about strabismus, even in exams, make sure that you always have to talk about the visual acuity, because amblyopia is one of the basic parts of strabismus only. So before we move on to strabismus, we would quickly revise about visual acuity. It has to be evaluated separately for each eye, and it is easier in adults, difficult in children. Why it is difficult in children? Because they are in a phase where they are growing. So you have to use age appropriate visual testing methods. So these are the milestones which you should be aware of, because you can't expect a 6 months child to really read, or a 1-year-old child, pre-verbal child, to read on Snellen. So you have to have the background. You have to know what exactly you are looking for before you reach out and see. At 3 months he would be reaching out. At 4 months we know the foveal differentiation will be complete. At 6 months there will be a good stereo acuity. At 9 months he would be picking up small objects. And so this is, by 10 years, it is end of critical period. So this all based with this background, you should be moving towards, this is just to show you that, a newborn infant can imitate some basic expression of mother, and a 2-year infant tries to talk with his favorite doll. And likewise, you have to know about these things. These are different type of visual acuity testing: detection, resolution, and recognition. You should have a fair idea of what you are actually looking for. Without that, you cannot really make out whether the child is able to fix or not. So when you are checking for strabismus, you have to check for amblyopia. You have to check whether the fixation is central, steady, or maintained. And the another most important part and parcel of strabismus is a good retinoscopy. Most of the good strabismus surgeons, or most of the people who practice good strabismus, are very good in their retinoscopy. You have to have a good refraction, because you see strabismus, the motor aspect of it is completely controlled by our accommodation and convergence. So there are a lot of factors which come into play. You may give an undercorrection to a hyperope who may be having a partially accommodative esotropia, and erroneously may be put on your operation, in an OT schedule. So you have to know that the refraction is good. even if you have a good optom, make it a point that you have to check the optom's retinoscopy. You have to assess your working distance. You have to subtract accordingly. And atropine 1% is obviously the gold standard, but we cannot use it at a certain age because they have to go to school, they have to attend their studies. And so you can use home atropine drops for older children. That is what we practice. So we come back to what the topic was. The first part of the topic was motor evaluation. And the best part of strabismus, I think, lies in its simplicity. There are no complex gadgets. It is purely, it is purely these things. It is purely accommodative target, an occluder, and a distance visual acuity test. So I think the best part of strabismus lies in its own simplicity. Motor evaluation will encompass mainly the cover test, and the best part of cover test is that the single first step, cover test, gives you all this information. Sometimes, in the exam, they ask you, they ask a short note on cover test as to what does cover test tell you. Cover test will tell you the type of deviation, whether it is foria, tropia, unilateral alternate, amount of deviation, fixation pattern, and this fixation pattern will tell you whether there is a latent nystagmus, whether it is concomitant deviation, depending on fixing right eye, fixing left eye, and presence or absence of amblyopia and dissociated deviation. So nothing is left behind if you are good. If you are good in observing what happens in cover test. So the cover test includes the cover, uncover, alternate, prism cover test, and corneal reflection test. So corneal reflection test is not basically a part of cover test, but when patient is walking inside your clinic and you want to write it down whether he has ESO or EXO, whether there's a manifest deviation or not, you can do a corneal reflection test. But we never rely on corneal reflection test as far as our surgical plan or treatment plan is concerned. So the tools needed for cover test are: never use a torchlight. Torchlight is no completely. So you cannot use a torchlight. Torchlight is only for corneal reflex test. It is meant for people who want to judge whether it is ESO or EXO. That's it. And that is also just a reflex test. Whenever you want to do a cover test, you have to use a fixation target for near and distance. Why do you need a fixation target? Because you want to control the accommodation. You want to know whether he is accommodating or not. Same is true for the cycloplegic refraction. Why do you want to use accommodative target? Because you want to know whether he is accommodating and his AC by A ratio is high for near or for distance, whether he is what is the angle in near and distance, and whether there is any incompetency between near and distance. And you have to use a prism bar or a prism, loose prisms, for measuring the amount of deviation. So what is corneal reflex test? Pretty simple. With the help of torch, you make an estimate or a guess of an angle. If the light is nasal to the center of the pupil, it is EXO. If it is temporal to the pupil, it is ESO. And this is a very common question, Viva. What is for each millimeter of eccentricity, what is the amount of angle you have? And the common answer is 7 degrees. How do you come to this 7 degrees? This is Hirschberg's corneal reflex test. In fact, he published it in 1885. So that was almost more than 100 years back. How do you come to this 7 degrees? He used a candle, and he saw that whenever the reflex of that candle was at the limbus, it was 45 degrees. And so the corneal diameter is approximately 12 millimeters, and that is how you come to 7 degrees. So this comes to the first step, which is the cover test. You have to break the cover test into cover test, cover, uncover test. Never rush to alternate cover test. Always remember, alternate cover test is meant for foria. It is not meant for tropia. When you do not see any manifest deviation, when the patient is absolutely bang on target, there is no angle in primary position, you have to do alternate cover test. But what happens is, in the jest of doing the examination quickly, what we do is we take out the occluder. We know he is left eye EXO. We cover his left eye, right eye, left eye, and that is how we write alternate EXO. It is never alternate EXO. If you are using alternate cover test, it is bound to be alternate EXO or alternate ESO, because you have never given a chance for the eye to come back to take up the fixation. So this is this is cover test. You covered the fixating eye. You have to cover the fixing eye, because if you cover the non-fixing eye, you don't get any information. It is already not fixing. So what information it will give you? Nil. You have to cover the fixing eye and see for the response of non-fixing eye. it's very simple. You know, a lot of times postgraduates would say squint is so difficult. You just have to cover the fixing eye. Do one step at a time. Just cover the fixing eye. And you cannot keep it covered for your lifetime. You have to uncover it. So you uncover it and see what happens. So you covered the seemingly fixating eye, and then and this is basically alternate cover test. You covered the same one eye, and then you uncovered it. The eye lost its fixation and came back. So if you go back, yeah. So here you cover the, okay. You cover the fixing eye. What happens? This eye takes up the fixation. And then you uncover this eye goes back. What does it say? What does it mean? It is left eye exotropia. Simple. What if that eye would have retained the fixation? What if left eye would have retained the fixation? It was alternate exotropia. And then you have to guess whether that eye maintains fixation with a blink or closes the eye and then gets back. But that is a second step to find out which is the dominant eye. Here you want to find out whether it is unilateral exotropia or alternate exotropia. So that is how you do a cover test, and this is for alternate cover test. So, okay, we go back. So what do you do in cover test? This is the first step. You cover the seemingly fixating eye. Why do they say seemingly fixating eye? Because whatever eye you feel is fixing, you have to cover that eye. And then wait. What will happen? The non-fixating eye is to be observed. If it moves from out to in, it is exo. If it moves from in to out, it is iso. From up to down, it is hyper. If down to up, it is hypo. Simple. We'll see a small video. The left eye is the seemingly fixating eye because the observer is sitting on this angle. So you cover the left eye. The right eye takes up the fixation from out to in. So it is right eye exo. Don't go into details of what happens to cover uncover test. We will see that. But right now, when you covered the left eye, right eye came in the center. The next step is cover uncover test. As I said, you cannot hold it for the lifetime. You have to leave the cover. So you removed the cover. What would be the response? There could be only two. One, the fixing eye may hold the fixation, which means the eye which was not fixing took up the fixation and is holding the fixation. That is alternate tropia. Second thing is that it goes back to where it was, and that is unilateral deviation. So then you have to find out whether it is which one is the master eye. So you can the eye which may hold fixation may lose it after a blink or a movement, and then it is alternate deviation with one of the eye being dominant or with one of the eye having mild amblyopia. So that is pretty simple. So this is just a video to show what happens to uncover. So the moment you uncover, it goes back. So it is a unilateral exotropia of right eye. You covered the left eye, right eye came in the center, you uncovered the left eye, the right eye again went back, and so what it is right eye exo. So when do you do alternate cover test? See, the word alternate is not to be confused with alternate cover test and alternate tropia. Alternate cover test is when none of the eye is fixing. If none of the eye is fixing, you want to find out whether there is any hidden deviation or whether there is any latent deviation. So what do? You try to make sure that the eyes which are straight, because of his fusional reserves, you want to break the patient's fusional reserve. And to break the fusional reserves, you do a alternate cover test. Sometimes you may not be able to break his fusional reserves just by alternate cover test, and then you do a occlusion test for 45 minutes, right? In earlier days, they used to occlude the eye for almost a week, but they found out that if you occlude the eye sufficiently longer, which is almost 45 minutes, you can still get the deviation if the patient has very strong fusional reserves. So this is mainly to break the fusional reserves, and it is in such a manner that at no point of time both the eyes are open. So you do alternate cover test and then try to find out whether it is a latent deviation, whether it is a hidden deviation, and you try to manifest that particular hidden deviation. So this is just an animation to show when both the eyes are straight, you covered this eye, and then you went to another eye. This eye came in the center, this eye went out, and then you went here. So you are doing an alternate cover test to break the fusion. Alternate cover test is to be done when there is hidden deviation. So the result which you get out of alternate cover test cannot be alternate tropia. It has to be phoria or intermittent deviation. It cannot be tropia, right? Because you did it when both the eyes were straight. And second indication of alternate cover test is when you want to measure the deviation. Why do you want to do alternate cover test when you want to measure the deviation? Because you want to find out the total amount of deviation that patient is having. Whenever you want to operate a patient of strabismus, you want to find out the maximum angle that he is having. Because if you operate him for a lower angle, he may still have a residual angle which he was fusing or which he was able to fuse, and that may become manifest whenever he is tired. So strabismus changes whenever the patient is tired, whenever he is not happy. If he is not happy with the examiner, he may go into accommodation, he may be having convergence. So you have to find out the maximum angle, and maximum angle you can get only by alternate cover test. So yeah, so this is just to cover. You covered this eye came back, you left, you went back there. Yeah, so this is these are just the videos of the same thing. We have to cover a lot of ground. So what is PRISM cover test? PRISM cover test is when you want to measure the amount of deviation. When you are sure that patient does not have amblyopia, or he is alternating, his vision is good, patient has come to you, you want to operate the patient. Before operating the patient, you want to measure the total amount of deviation patient has. So what you do, you keep PRISM apex towards the deviation, but when you write in your notations, you write base in. Which means if patient has exotropia, you put the PRISM in front of that eye, apex towards the deviation, which means apex will be out in a patient of exotropia and base will be towards the nose, and then it is written as base in. But you always remember in such a way that apex towards the deviation. So then for ESO it is base out, for exo it is base in, for hyper it is base down, and for hypo it is base up. You can always do, as I said, you can do an extended occlusion if you are in doubt that patient is having good convergence and patient is having near distance disparity. You can either do a PRISM adaptation test, or you can do a Scobie-Marlowe's occlusion test to find out the total amount of deviation. You have to find out the total amount of deviation before you embark on operating the patient, because you have to operate for the hidden angle also. You just don't have to operate for the manifest angle, you have to operate for the latent angle also. So yeah. So this was just an animation. This patient is having exo. We have covered the fixing eye, and then we keep a PRISM in front of that particular eye, and then we keep on doing alternate cover test till there is no movement of reversal. So you have to keep on doing alternate cover test and keep on increasing the amount of PRISM till you get a movement of reversal. So first you will get point of neutralization, and second you will get point of reversal. Point of neutralization means that there is no movement of redressal, which means that the exo deviation eye, the eye is coming from out to in, will stop coming from out to in, and then if you put a higher PRISM, the eye would start coming from in to out. That is the angle of reversal. You have to measure both the angles, because the difference between the two angles is the amount of fusion which patient is having. So this is Krimsky's test. In some of the patients, when you want to measure an angle and patient doesn't have good vision, so for a PRISM cover test, you need to have good vision in both the eyes. So when the patient is such that his vision is not good, or he is not letting you do a alternate cover test, you can see the mother is holding his ears. He was really a uncooperative child. So she is holding his ears, and he was a partially accommodative esotropia patient. We'll put glasses. He had around 6.5 diopters of hypermetropia. So we will give glasses, and he would still be having, with glasses also he has small angle, but because he is very young, he is not very cooperative for alternate cover test. We can do a Krimsky just to note what is the amount of deviation that he have. So Krimsky is very similar to alternate cover PRISM cover test, except that here what you do is you put PRISM in front of either fixing eye, so that when you are increasing the PRISM in front of fixing eye, the non-fixing eye will start coming in the center, and the point where you see that light reflects is in the center of the pupil in the non-fixing eye. You can say that this is the amount of deviation which patient has. So this was a Krimsky's test. And then once you have finished your cover test, you have a fair idea of what patient has, whether he has concomitant deviation or not. So before going for surgery, you have to do certain more tests, and one of the most important tests is doing ocular movements. Ocular movements, we know when it is unilateral, they are known as ductions. When they are on the same side, they are versions, and when they are disconjugate movements, they are vergences, which is convergence and divergence. So vergence means dextroversion, levoversion. When you move both the eyes towards the left side, it is levoversion. When you move on the right, it is dextroversion. And then you have to know about what are normal excursions, whether there is an oblique dysfunction or not, and whether there is a committant or incommittant deviation that includes both patterns and near distance disparity and fixing right eye, fixing left eye difference, right. So normally they will ask you what is the difference between primary and secondary deviation. It is pretty simple. Primary deviation is when the sound eye is fixing. Remember, the word sound eye is very important. When the sound eye is fixing or the unaffected eye is fixing, it is primary deviation, and when the unsound eye or paretic eye is fixing, it is secondary deviation. It is secondary to the paretic eye, and normally secondary deviation is more than primary deviation in a case of paresis, right. So that you have to look for. This is just to, these are just small videos, we can quickly finish them off. This is just to show you the normal ductions, and this is just to show you how can you measure for convergence amplitude, because basics of strabismus is very big topic. So you can just see these are the normal excursions that we are trying to measure, and here we can just see a patient of inferior oblique overaction who has a V pattern. So I cannot go into details of why oblique will create a V and why superior oblique will create an A pattern because of torsion and because of horizontal muscles. We can take that at some other time, but this is just to show you various things. This child has, this is left eye inferior oblique overaction, and adduction there is elevation of the eyeball. And when you have an elevation in adduction, it is inferior oblique overaction, and when you have depression of the eyeball in adduction, it is superior oblique overaction. Normally, superior oblique overaction would be associated with A pattern and intorsion, because superiors are intorters, both superior rectus and superior oblique. If superior oblique is overacting, there will be A pattern, and if inferior oblique is overacting, it would be V pattern, because both the eyes will extort. In the up gaze, there are inferior obliques are abductors and superior rectus are adductors. If inferior oblique is overacting, it will pull the globe out. That is one theory. Another theory was proposed by Guyton and Mims in '94, where they said that both the eyes are extorting, so superior rectus goes on the outer side and becomes more of an abductor rather than an adductor, which is the tertiary action of superior rectus. So that was regarding. I've been cut short. Yeah. So ocular movements, this was something which we had done in 2010, and this is what we you can measure the amount of deviation. This is just kept to. Thank you. So this is just to show you what are the normal movements: normal adduction, abduction, supraduction, and infraduction, and so this brings in short an end to the motor aspect of strabismus. Sensory aspect is little more, we will try to short it down. So this was, see, one thing you have to understand is that binocular single vision cannot be graded. The reason why it has been graded by Wirth into simultaneous perception, fusion, and stereopsis is only because he wants to classify it. He wants us to understand that these are the three grades, and stereopsis is the highest grade of binocular vision. There can be variability. It all depends on which type of test you are doing. If you are doing a little more dissociative test, you may have less stereoacuity, your fusion may not be there. Like if you are using a synaptophore or a Wirth 4 dot test, or you are using a red-green glass, the disparity is huge. Whereas if you are using a Lang's or a Frisbee's stereo test, the disparity is not much, because it is purely physiological. You are not using anything to dissociate the two eyes, right? This was heavy. See, whenever you are measuring the sensory status, you are using something to see whether two eyes are working together or not. For that, you have to dissociate the two eyes. There are different ways to do it. Either you can use a red and green glass so that you know which eye is red, which eye is green. Second thing is, you can use polarized filters, where you polarize the light vertically and horizontally and use a Titmus test. Third thing is, you can use a Lang's test, where there are cylinders incorporated inside that plate. And fourth is a Frisbee, where there is actual thickness of the Frisbee plate where that is the true stereo acuity. So if you change the type of test which you are using, you will get different results in the same patient, because his convergence, his IPD, his amount of stereo acuity depends how much you are dissociating him. So the most physiological test is obviously Frisbee, and then Langs, and then in that order Polaroid glasses like Titmus, and then red green, and then synaptophore, and then after image test, which is the completely dissociating test. So in after image test, you cannot suppress. See, you cannot suppress after image because it is foveal test. See, all the other tests are not foveal tests. After image test, you stimulate one eye, then you close that eye and stimulate another eye. So you are separately stimulating the both the eyes, and then you are asking the response. So in foveal test, the response will be reverse of other test, which means in ESO there will be cross diplopia, because it is stimulating both the foveas. Remember, in our diplopia thing, what happens is that extrafoveal point is getting stimulated, which is there at temporal aspect, and so you get cross. In a ESO you get uncrossed diplopia, but in a foveal test you will get cross diplopia or a crossed image in after image test, which is the foveal test. So after image test is a very dissociative test. In after image test you will not have suppression because foveas are getting stimulated separately. This is just a short of what I was plan to tell in this. So what is the prerequisite for binocular single vision? Images should be on corresponding retinal elements, and they should be approximately same size and shape. This is all theory. We can I would just like to tell what is suppression and what is, I think this even you people can easily attempt and tell what is suppression. Suppression is, you can read from this. So suppression is basically when one of the eye in presence of, when both the eyes are. How is suppression different from amblyopia? Amblyopia is even if you close one of the eyes, patient is still not able to see, whereas suppression, when both eyes, patient can have 6/6 vision and yet have suppression. Why? Because it is a binocular thing. Amblyopia is a uniocular thing. In suppression, when other eye is open, this eye is getting suppressed actively at the level of brain, whereas in amblyopia visual acuity has gone down. That is different from suppression. So don't confuse suppression from that. Similarly, ARC is different from eccentric fixation. Eccentric fixation is monoocular. Even if you cover the other eye, he will still have eccentric fixation. Here, the fovea of fixating eye acquires an anomalous common visual direction with the peripheral retina. So ARC can be complete or incomplete, which means it could be either harmonious or unharmonious. What is harmonious ARC? Harmonious ARC is the complete change in picture, which means that if patient has a 10 prisms esotropia, his angle has his location in the inside the eye has also gone to 10 prisms, which means objective angle will be 0, which means that he has completely adapted to that particular angle. When he is in between that, it is unharmonious ARC. I know it is difficult to imbibe ARC and things like that at this level, so quickly we are going into it. So unharmonious is when the adaptation is not complete, and harmonious is when the adaptation has taken place completely. And these are some of the tests. We will just see. Yeah, so this is a good, we'll just show this video and then we will see the last 2 slides. So Worthford dot test. What is there in Worthford dot test? We have red green glass and there are 4 dots. See the simplicity, see the best aspect of this test is that you just need red green glasses and you need 4 dots, and you just have to ask the patient whether he can see 4 dots or not, whether he is able to see 3 dots or 2 dots. The 2 dots have to be red because one is already there and one is white.
So
and
you will have to wipe out.
Yeah, just
yes.
I'll just show the stereo acuity, what are the tests available. This is the stereo acuity test, TNO, Langs and Frisbee, which I was talking about.
So thank you very much, sir, for a wonderful